Good morning, everybody. I'm Dr. James Lehmann. Thanks for joining. I'm going to try to get everything going. Okay, so good morning. Welcome from San Antonio, Texas. Hope your Mondays are beginning nicely. We're going to be talking about the transition from DSEK to DMEK. A little bit about me here. I'm in private practice in San Antonio, Texas. I do a mix of cataract, cornea, and refractive surgery, and mostly DMEK these days. And I've had the fortune to work many times with Orbis and with SightLife doing cornea training programs about DSEK, DMEK, and PK all over the world, most recently in India. So I have some experience teaching and doing wet labs and such. A little review of what we're going to talk about today. We're going to go over the background, how to pick donor for DMEK, how to evaluate the patient, prepare the donor, what instruments are needed, how to prepare the recipient, load the donor, and the steps of surgery. Before we get started, we're going to do a few preliminary questions. Just so I get an idea about the audience skill level and experience level, rather, I just want to know if any of you have performed any DSEKs. And we'll give it about 20 seconds, and Lawrence will show us the result here. Okay, we got none. Okay, so most people here are just learning. Okay, we'll go to the next question. How many DMEKs have you performed? All right. The next one would be, I have access to prepared DSEK tissue. So this would be that your eye bank is able to prepare DSEK tissue for you to use, or do you have to harvest the tissue and prepare it yourself? Okay, well, most of you have an eye bank that gives you available of that, so that's good to know. Okay, we're going to do the last one is my eye bank would give me prepared DMEK tissue. Okay, about 50-50. Okay, now we're going to just do a few questions about what we'll talk about today. Which of the following would be a contraindication to DMEK? A patient with an OMED tube, an aphakic patient, poor view, iris defect, or peripheral anterior synechii. So which one you couldn't do a DMEK in? Okay. All righty. Keep moving along. Okay, so a cornea preserved in Optisol can be preserved for 5 days, 10 days, 14 days, or 18 days. All right, and last question. In DMEK phaco, what should the refractive target be for plano results? So if you have a patient that you're doing a combined procedure, should you aim for -2, -1, plano, +1, or +2, if your goal is to be around plano? Now, there's always some variability, but that's the idea. All right, so that looks pretty good. All right, so we'll go moving right along. All right, so background. This is what keratoplasty was in the 40s. This was Dr. Castroviejo in New York. This is a graft done with a square graft. You can see that it's not round. They used a double knife and would prepare these and use either steel or silk sutures at the time. And this is what we had for any kind of corneal disease until the early 2000s. So it was one size fits all. And as endothelial keratoplasty evolved, now we have so many different kinds of options. But it was first pioneered in 1998. Dr. Mellis did what was called a PLK, showing an air bubble could be used to stick tissue to the back of a cornea. And then Dr. Terry, in 1999, did what was called a DLEK. That's the picture in A right here. It was very difficult. You had to do posterior trephination. And so it didn't really catch on until around 2004, when microkeratome was used to prepare DSEK tissue and made it more standardized and more that decreased the learning curve a little bit and made it easier to adopt. And that's picture B here. And then Dr. Mellis again in 2007 did the first DMEK, where we're just doing anatomic replacement of the diseased tissue. So DMEK is precise anatomic replacement. You can see in this picture here, that's a post-op day 1 cornea, how clear it is. So they have better vision. They have less refractive shift than DSEK, for example, definitely than PK. But there's a learning curve, and there are possibly fewer candidates because it requires, because of the surgical steps, it requires mostly normal anterior segment anatomy. Here's some statistics from the EBAA, that's our United States Association of Eye Banks, and you can see the number of PKs is pretty stable. and you can see the number of DMEKs increasing, okay? So from 2013 to 2017, the number of endothelial procedures has stayed about the same, okay, or increased by 4,000 there, but the percentage of DMEK has gone from 6% to 26%. So it's definitely growing in popularity. And so how do you know if you're ready to start doing DMEK? First of all, you have to have some experience, a cornea fellowship, either a short-term one or a full year. You have to have some experience doing penetrating keratoplasty. I would suggest at least 25 to 50 PKs to give you an idea about how to hold, manipulate tissue, and then suture as well, and then about at least 25 DSEK. Now, the skill set involved in DMEK is different than DSEK, and a lot of surgeons now learn it at the same time in the United States in their cornea fellowships. But what DSEK teaches you is about air management, bubble management, how to pick the right patients, how you can deal with postoperative complications and such. So I think it's important to have done DSEK prior to learning DMEK. And then most importantly, you need to participate in a wet lab, either with somebody in your local country who's got experience with this, or attend one at one of the national or international meetings. But you have to learn about donor preparation, especially if your eye bank can't prepare it for you. And that's a skill unto itself that requires practice on research tissue. You also have to learn how to load the donor, and you have to learn about graft manipulation. You can do all of this in a wet lab so that when you're ready to do your first cases, preferably under the supervision of an experienced surgeon, that you're going to be able to have that success that you desire. So a little bit about donor selection, because it is different than DSEK and PK. So, and DSEK and PK are pretty similar type criteria. You want a young, healthy cornea with these nice numbers here on the side. Many of you already know about these. In the United States, when we're offered a cornea, we receive a tissue detail form like this. And what's nice now is down here, what I'm showing is the endothelial picture. We used to not get a picture, we'd get a count, and the counts aren't always accurate, as you know. But the picture is, and you can see uniformity of the endothelial cells, nice shape, and this makes you very confident that it's a good cornea. They're able to reheat the corneas quite fast to take nice pictures like this. And that's something that we only had over the last few years. So in a DSEK or PK, again, you want the age of death to be 15 to 65. You want it 12 days or earlier. The D to P, 20 hours if it's refrigerated, 10 hours if it's not been. And then you want cell count of at least 2,500. DMEK's a little different. So here we don't want young corneas. The scrolls are too tight, and they're harder to harvest. So 45 to 65 is kind of the sweet spot for me. We don't normally like pseudofakes because preparation can be difficult. There may be some cuts in the endothelium that you can't see. And then diabetic donors, there's a little bit of controversy of whether there are more tears during preparation. I think this is kind of not an absolute contraindication, but especially when you're preparing tissue for the first few cases, you don't want to use a diabetic donor. Some important studies about corneal tissue. You know, the corneal donor study showed us that you can use older corneas, and more recently, the corneal preservation time study showed that you can have success with DSEK and with any age corneas from 0 to 14. And there was no significant difference in the results, the primary graft failure or the 3-year survival rate up to 12 days. So for many of you that live in countries where you import tissue from another place, I know there's always been reluctance to use corneas after 8 days, but I think the data show that up to 12 days, you're not putting yourself at any disadvantage. So I would encourage you to use cornea tissue up to 12 days. The different preservation solutions, you know, the most popular now is Optisol GS. In the United States, you can now ask for it with amphotericin B in it, and there's a little bit of debate about how useful that is. But I know in other places you guys use the MK media just because the corneas are used so fast. The preoperative evaluation. So the decision here, since we're talking about transitioning from DSEK to DMEK, is which one do I do? What type of anesthesia do I use? And, you know, how well does the patient cooperate? So when you're trying to assess to do DSEK or DMEK, you want to determine how difficult the case is. How complex is the anterior chamber? How clear is the cornea? How easily may I be able to maintain and control a bubble? For me, the main contraindication to DMEK would be having an ACIOL. You'd have to either switch it out. You can do a DSEK in a case of an ACIOL. I never forget that DSEK is a good option. So we'll get into this a little bit more. So how to decide, okay? So this pain scale I have here, it's not a patient pain scale after surgery. It's a preoperative, how painful will that surgery be for the surgeon? And here what you want to look at. You want to say, what's the complexity of the anterior chamber? How extensive are their PAS? Is it a shallow chamber? Is there a valve present? Was there a history of angle closure? Is the eye small? Is there any possible way the patient has vitreous prolapse? And is there an ACIOL present? How clear is the cornea? Most of the time, you can improve the view tremendously just by removing the epithelium, but you want to try to get an idea if there's extensive scarring or not. Lastly, you want to talk about bubble management, and that would be, are there iris defects? Is there hypotony? Would there be ways that the bubble can't be maintained firm in the anterior chamber? And lastly, you want to assess the lens status and decide between proceeding with a pseudophakic posterior chamber lens or doing a combined phaco or doing an IOL exchange if there's a problem with the current lens. So here's some pictures of some complex cases. All right, here you have an old style ACIOL with corneal edema. Here, a modern Alcon style ACIOL. Here, extensive scarring. Here, aphakia with iris defects. So all of these may not be the greatest candidates for DMEK, right? So you could do DSEK depending on the age. You also could do a staged procedure in which you remove the ACIOL, suture a PCIOL to the sclera, and then proceed with other surgeries. So this is a good tip, is you want to do pre-op anterior chamber OCT in complicated eyes. This is going to help you to plan your surgery and to make sure you don't have any surprises when you start the surgery. It'll help to determine if there are any membranes, how extensive are the PAS, etc. So I recommend this, especially on your when you don't have a great view into the anterior chamber. We'll also talk a little bit in this preoperative management about lens management. So you can do a combo case. That would be if the patient's phakic with a cataract. If they're pseudophakic, what I want you to do, you need to dilate that pupil and verify the stability of the IOL. If it's a pseudophakic bullous keratopathy patient, they probably had rough cataract surgery, and you need to verify that that IOL is nice and stable. If they have an ACIOL, you can either do DSEK or you can remove and replace it, but you cannot do a DMEK in a patient with an ACIOL. I say that, and I'm going to go to the next meeting, and somebody's going to show a video of somebody doing a DMEK with an ACIOL. If they're aphakic, I would recommend a secondary IOL, and then a month later DMEK or DSEK, depending on the other parameters. So when you're doing cataract surgery in combination with DMEK, there is some hyperopic shift, but not as much normally as with DSEK. So you want to aim between -0.5 and -1. I would suggest a single piece acrylic or silicone IOL. And then you need to be aware that there's going to be change in the axis and the magnitude of the astigmatism. So this is a little unpredictable. I'm doing a little paper right now trying to figure out if there's any pattern in this, but I would not go with any kind of toric or multifocal IOL in these patients unless they had lots and lots of astigmatism and you were just trying to debulk it, not necessarily guarantee, glasses independence. So when there's a combination of phaco and DMEK, often the cataract is harder than the DMEK part. This is a case, I'm showing a video right here of a dense cataract and corneal edema. You have to avoid any complications during the cataract part because that will set you up for failure with the DMEK part. So no tear in the anterior capsule, definitely no tear in the posterior capsule. You have to make sure and be diligent that there's no residual cortex or nucleus and that there's no iris damage because that's going to cause bleeding and fibrin that can make the phaco part more difficult. So we're not going to show this whole video, but you can I just kind of wanted to demonstrate the difficulty in the view. And so I'm putting vision blue there, tiny pupil. Here we're putting some dispersive viscoelastic. So you have to be I have to be an experienced phaco surgeon to be able to do these type cases. Otherwise, you could have maybe like the best phaco guy or gal at your institution do the case, and then you come back later. There's no shame in doing a staged phaco DMEK at all. So in fact, in your first cases, you definitely don't want to do these combo cases because they're much more difficult in terms of getting the graft to behave nicely because you don't have a tiny little pupil. So I'm going to fast forward a little bit here just to kind of show that it's, you know, the phaco part is really the hardest part in these procedures. All right. So if somebody has a failed PK, oftentimes you want to determine would they be better off having just a full-on repeat PK, or can you just fix the endothelium? So there's always the issues that go into this, but you can do DMEK in these cases. And they're difficult because you have to strip inside of the margin without disturbing the graft-host interface. Also, you want to make sure that you measure the diameter of the graft, and when you order the tissue, if you're ordering the DMEK from the eye bank, you need to order a smaller size than this so that it can fit. The main determinant in this, which would be for a different lecture, is if the patient had a lot of astigmatism or very irregular surface, you're probably better off just repeating the PK because that's going to be an issue if you just do an endothelial keratoplasty. But if they were seeing well and glasses or contacts, an endothelial keratoplasty alone is probably a better idea than a repeat PK. Again, that can get a little complex. But in these cases, so this would be glaucoma surgery. This is probably the second most common referral I get is patients had multiple glaucoma surgery and now has corneal decompensation. You can do these with these pseudophakic cases can definitely be done with DMEK. You need to have experience. They're harder cases. Sometimes you have to trim the tube. The view may be poor. You need to do gonioscopy, assess the extent of PAS. And you have to also think about the visual potential. If this is like a count fingers eye, a 2400 eye, maybe they're better off just doing a DSEK if you're more comfortable with that technique. Nobody has looked at survival rates of DSEK versus DMEK in patients with tubes. But DSEKs, they don't last so long in these eyes either. Like they last 5 years, if you're lucky 5 years. So it'd be interesting to find out as more and more people do DMEK, if DMEK ends up more successful than DSEK in these eyes. So a summary of the preoperative planning. The anesthesia that I recommend would be peribulbar. You also want to make sure the patient can lie flat. In case they need to, so that they can position after surgery, and additionally, so that they can lay flat in the clinic for a rebubble if they need it. The best first cases are patients with Fuchs dystrophy with good visual potential, and that eyes that either just had cataract surgery or are going to be staged cataract surgery and then DMEK. You need to avoid eyes with complex anterior segments, and then I like to perform the iridotomy that's inferior 1 week before with a YAG. If the view's not as good, you can use a vitrector during surgery as one of the initial steps, just without not fluid coming in, just using viscoelastic in the anterior chamber and using INA cut. So a lot of doctors do it that way, especially if the eyes that you're operating on are have very poor views. So we talked about the anesthesia. People do these under topical anesthesia, but I prefer peribulbar. And again, patient cooperation. They need to be able to lie flat. They also need to be able to tolerate a rebubble in the office just with drops if that's going to be necessary. So it's good to have that talk with the patient. And then we talked a little bit about the ACIOL, like which ones would you leave in place? And this goes for DSEK, not DMEK, but if the eye is quiet and they've had the ACIOL forever, they have normal pressure, and maybe the other eye is blind and this is their only eye, like a 90-year-old patient, you probably don't want to do a staged surgery in which you have to suture an IOL in and then do a DSEK or DMEK, especially if they're an anticoagulant medicine, because those sew-in IOLs are rough surgeries, and they can be you know, on a monocular patient, they can be risky, and they may not be able to stop whatever anticoagulant they're taking. So again, there's a lot to consider, but the main take-home point is if the eye's been quiet and the cornea just is decompensated because of its proximity to the ACIOL, especially if they're monocular, you may want to just do DSEK and not the staged type procedure. Here's some old style ACIOLs that we see sometimes. And then just like I said, if you're going to do an exchange, I prefer to do it in 2 surgeries. I like to do an IOL exchange with a sutured IOL and then either a DSEK or DMEK. I feel like if you combine them, it's a very big surgery and there's a less chance of success for the graft. And so that's what I vote for, is a stage surgery when you're going to do an IOL exchange. And then we talked about a little bit about aphakia, trying to determine if you could do an EK or a PK. You got to first determine if there's a need for an IOL, and if so, again, the stage procedure. If not, you can do DSEK in this easier, in my opinion, because you can put a safety suture through it. And if the eye has been vitrectomized, especially, the bubble is pretty straightforward. So I vote for DSEK in these patients. And then here's a little picture of Cinderella in the glass slipper that doesn't fit the stepsister. When is PK still better than endothelial keratoplasty? Because in some cases it is, and that's when there's a lot of stromal scarring or haze. If the patient's had pseudophakic bullous keratopathy for 3 years, 4 years after cataract surgery, and the view is awful, and then oftentimes I've done like a DSEK or a DMEK in that patient, and then it turns out they don't see well because I underestimated the extent of the stromal scarring or haze. Also, if there's high astigmatism or irregular astigmatism, they may be better off with a PK. So preparation of the donor. The way that this has evolved in the United States was we first used to do it in the operating room. And I'll kind of zoom in on this video in a little bit. But it's evolved now where the eye banks in the US do it. And the reason for that is because of time, money, and risk. If you tear a donor, you're responsible, or your surgery center is responsible for the payment on that. And that's not the case if the eye bank prepares it. It's kind of evolved even further now where they stain and mark and load it for us. And so now I'm getting my DMEK tissue in this bottom picture here. It's already pre-stained in a glass cannula. And so a little bit more on the preparation. This is the technique that I still use. And you start by using what's called a Beckert Y hook. Now, what is it sitting in here? Well, this is a viewing chamber, so a plastic viewing chamber under an operating microscope in Optisol. And what you're trying to do here is you're trying to go about 1 millimeter inside of the limbus where you have a clear zone, and you're scoring. Now I'm going to start speeding up the video. And you're scoring Decimates all the way around here. Now, what's the point of this? This is where you're going to get that edge, okay? And there's going to be some tags that happen where some of the tears start to run a little bit. But you want to go all the way around with moderate pressure in order to get a 360. Then you stain it, and you can see where your tear was, okay? And then you go and you remove these tags. These are not connected to anything. And then you use an instrument like a Sinskey hook, or this one's called the Moriya microdissector. And what you're doing is you're starting to lift that edge. This is the most tedious part, but also the most fun, actually, because what you're trying to do is get that edge lifted without causing a tear. And you have to go 360 degrees around. You can't skip any areas here. And the idea is to get an edge lifted all the way around. So I'm going to let you see this a little bit. And then now when eye banks put S stamps on it, they put a hinge in the temporal or the lateral aspect of the graft. But what I'm demonstrating here, since I learned before we used to have S stamps, is we peel until the central 3 millimeters. So now that edge is 360 free, and then we're pulling it to the middle. And you want to pull it to the middle in all 4 directions. Here you can see. So it's been pulled to the middle in all 4 directions. And then you lay it back down and you do the trephination. And you don't want to do full thickness trephination because then you lose the edge. You just want to tap the trephine using a nice new sharp one, and then restain so that you can see the edge of your graft. And now you can see that it was cut nicely. And then the proof that it was cut 360 is you pull off this little ring of that edge of tissue that you had prepared. And so what you have here is an 8 millimeter DMEK that's attached only there in the central 2 millimeters of the cornea. So that's the technique that I use. Well, now it's been prepared for me. I don't have to do that, but you still need to know it. And honestly, in most countries, you're going to have to be preparing the donor yourself. So like I visited doctors in India and everything who can do that way faster than I can. They can do it like in 10 minutes. And so there's different techniques. That's just the one that I use. And here are the instruments that I use for that. The 2 that are kind of unique are this Y hook down here, and then this microfinger or microdissector by Moriya. The other stuff is pretty standard. And then if you want to put an S stamp on it, you can find videos on the web about how they do use a derm punch. that's like 1.5, 2 millimeters, and then put the S stamp on the stromal side. The instrumentation during the surgery itself is basically a cataract tray, and then you need this guy, which is the reverse Sinskey hook. And I like to use a cohesive viscoelastic, so Helon, not a dispersive viscoelastic. I also use this, which is a handheld slit lamp. This helps me to confirm orientation of the graft. Now, there's many tricks for this, so you can learn other ways, but oftentimes, even if you use the S stamp, it gets distorted. And if you don't know how to determine the graft orientation, except for the S stamp, then you're kind of in trouble. So always need a backup. And what I use is this handheld slit lamp. And so I'll show you some pictures of that. So in the OR setup, you have, of course, the patient's draped, but then on a back table, you have the stuff that you need to load the donor. So you need some Vision Blue, you need a Teflon block, and a Petri dish filled with BSS solution. And then to load the donor, what I've evolved to now is using this goiter glass cannula that you can see in this bottom picture, where you suck it into the neck of the cannula with one syringe, and then you attach another syringe on the back. So for this, you need the goiter glass cannula. The benefit of this is you can use a 2.4 or smaller incision, and you use 2 syringes as well as the tubing that comes with the glass. So in the United States, this is single use, and now it comes with the graft already in it. But otherwise, it would be an additional cost at the time of surgery. Now it's glass, and I guess theoretically you could just re-sterilize it. So different countries have different rules about that, but unfortunately in the US we're kind of hand-tied in this respect. So the other thing you can use is an Iol Injector. This is the one that I recommend by Medicel AG. In the United States it's distributed by Bausch & Lomb, and it comes in 2 sizes. I recommend the 2.8 millimeter version. And there's a spring present in here that you need to remove prior to loading. So this is what I used to do. The other very popular technique in the United States is called the Jones tube, and it's similar to the goiter glass cannula, just a little bit bigger. So now we get to the fun part. Patient preparation. Oh, wait, almost to the fun part. Regarding patient preparation, like I said, patients need an inferior peripheral iridotomy. You need to do your IOL calculations, aim for about -1 to -0.75. It's good to know the white to white so that you know what kind of graft size you want. And again, I recommend peri or retrobulbar anesthesia. In terms of the surgical steps, first I like to place traction sutures, which is a little unusual. Most DMEK surgeons don't do that. Then you mark the cornea, you make the paracenteses, and then we'll go through all this. So the traction sutures. So what are we doing these for? Well, you'll see, okay? But here I use a 6/0 silk on a tapered needle, and it's good to have that tapered needle or a spatula needle. You don't want a cutting needle because you'll go too deep. But these are episcleral bites about 3 millimeters posterior to the limbus superiorly and inferiorly. All right, then the next thing is to mark the cornea. Now, why are we marking the cornea? Well, just to center the graft at the last step. So I use a blunt 8 millimeter trephine, or you can use an optical zone marker, and we want to kind of center it on the geometric center of the cornea, not necessarily the pupil. I also like it a little more nasal, because my paracenteses then won't interfere because I sit temporally when I do this surgery. So again, the incisions, you want them to start and end prior to that little line that I just made right here, because if not, then you have this tunnel going into where that graft is going to be sitting. I'm making 3 incisions here. This is when I used to use the IOL injector, and I like to have an AC maintainer, but nowadays I just make 2 paracenteses. Again, I send temporal, so these are 45 degrees from my temporal incision that's going to be right here. We're putting some blue in the eye there because it helps to do the rhexis for the cataract surgery. And then here's using a 2.8 millimeter keratome. So again, the take-home point here, you got your main incision here, you got 2 paracenteses 45 degrees away that are not so long. You want them in the plane of the iris, and you want them to stop before you get to this edge of where your graft is going to be. Otherwise, if you inject air into that later in the case, you're injecting air into the interface, and you're going to have to restart some steps. Okay, so here's the next surgical step, which is removal of Decimates membrane. This is a combined cataract DMEK, so I've already removed the cataract, and the IOL is in the bag here, and the eye has cohesive viscoelastic in it. So I go around twice, and I go just outside that little area that I outlined earlier. Okay, so you're overstripping about 0.5 millimeter or so. The reason for that is because you want a little leeway in that graft positioning. You don't want it to have to sit just perfect on 8 millimeter graft into an 8 millimeter hole. And so once you've gone around, then you go to the distal edge and you start peeling that Decimates membrane. And you want to make sure you have one big piece and that it's freed up on the sides here. And you can get good visualization here because of the red reflex. You know, one bad thing about a combo DMEK phaco is that you never really get the pupil as far down as you would like. And that can make graft unfolding difficult. But in this case, it is beneficial because you see Decimates membrane so clearly. So anyway, then you remove it from the eye. Again, here's another picture with a little better visualization. And you can see how I've gathered it up on the sides here, because if it's going to be attached anywhere, it's normally attached to wherever they had previous incisions or where you've made some. So, and then you just focusing in there. Nice. You don't want to make too aggressive movements here because you'll cause little gashes in the stroma that will leave tags or an irregular posterior stromal surface that can keep the graft from adhering 100%. So anyway, you guys get the idea. Try to remove it all in one piece. And it's really fun to do this because it feels like you're doing something you shouldn't be doing. All right. So that's halftime. Just want to make sure you guys don't have any questions or anything. Let's see. All right. And then we'll get into loading the graft and then steps of surgery. All right. I can't see if there are any questions. Guess there are none.
None at this time.
None at this time. Okay, sounds good. Okay, we'll keep moving. Thanks, Lawrence. Okay, so loading the donor. Remember, the donor's been prepped for us, or if not, this is what you're doing after practicing it many times in the wet lab. So when would you do it if you're loading? If you're peeling it yourself, you've done the first part of the DMEK, and you've done the PI, and then you put an air bubble in the eye and make sure there's no bleeding. That's when you're really good at it. In the beginning, you obviously want to do this before you do the case, in case you damage the donor and you're unable to proceed with the surgery. But once you get good at it, you can actually do the first parts of the cornea, first parts of the surgery before peeling the donor. So in this case, we've already had the donor prepared by the eye bank, and all we need to do is dye it with trypan blue and load it into the glass cannula. So here are the steps involved. So it's been prepped by the eye bank, and it's only attached here in the middle. So I'm lifting it. I can be aggressive there because I know it was only attached in the middle. I lay it back down into the donoscleral rim, and then I'm going to stain it with Vision Blue. So how long to do this? Somewhere between 30 seconds and 2 minutes, most likely. And then I'm using 2 Weck cells, and I'm going to get rid of all that blue dye. And what we're going to have left is a little folded up graft that's nice and dark and blue. All right, then you're going to pick it up, preferably at the same edge where you picked it up before, and you're going to transfer it into a Petri dish that's filled with BSS. And there's going to be some glare here, I apologize. But you lay it down, and then it floats, and you can see kind of how it starts to behave. It goes in its little scroll, and now you use the goiter cannula, and you use it where you've attached a 5 cc syringe to the narrow neck, and you suck it up into the neck of the cannula. And then you attach the 3 cc syringe to the back end of the cannula so you have an injector. And here's a surgery I did when I used to use the Iol injector. So again, remember it's already been prepped by the eye bank and it's just attached here in the middle 3 millimeters. So I kind of lost the grip there. This is a little bit of a different, same technique where we lift it out, but I'm going to fast forward here. Okay, so here we've stained it, and now we're putting it into a Petri dish, but there's a cartridge involved at this point because we're putting it in the cartridge. So I lay it in the cartridge, and then I'm going to push it up into the neck of that cartridge. All right, and then now I'm advancing the plunger of the cartridge. All right, and then you're going to see it. That's the graft right there. Now, we don't want the graft to shoot out the end of the cartridge. So at this point, you have to start rotating the tip of the injector up and being real gentle so that fluid comes out of the end, but the graft doesn't. And then you have the graft safely loaded once the plunger hits this point right here. And then you're ready to inject it, okay? And we'll show some examples of that. Here's one little thing that you should be doing is culturing the donor rim. Now, why is this? Because for endothelial keratoplasty has a much higher rate of fungal keratitis than PKs do. And it's really difficult to treat, and it seems like it's always Candida. So if you do a donor culture and it turns out to be positive, you need to follow that patient very closely. You need to treat them and possibly redo the transplant, even though it's a nice, beautiful eye that's quiet, because of the high risk of this interface fungal keratitis, which can appear years even after the surgery. So fortunately, this is very rare, but I think it's a good policy to culture your donor rims. So we'll go through the surgical steps of DMEK. First, you want to inject. Then you have to put a suture through your main wound. And then you got to get that graft in the right location and orientation. And then you got to stick an air bubble under it to make it stick. So that's simplified it, but that's basically it. So we're going to start with all the steps here. I got about 22 minutes. So here's an injection with the glass cannula. That's through a small incision, 2.2 millimeters, and pretty straightforward. Here's with an Iol injector, okay? So I have an AC maintainer, and you can see how much more difficult it is to put this injector in because it doesn't have so much a bevel. It's a little too flat. Then you can see the plunger pushing the graft forward while the AC maintainer is maintaining a big step. Then I remove the AC maintainer, and then you remove the graft. I mean the injector. So either way works, but you can see it's a little more elegant with the glass injector. There's no doubt about it. All right, so you got the graft in the eye. You did your suture to close that main incision. Now you need to get that graft in the correct position, okay? You need to get it centered. You have to have it in the correct orientation, and you have to unfold it. So how do you do that? Well, many surgeons have many different ways, so I'm going to share mine. There's basically 5 maneuvers you have to learn. You have to learn how to flip the graft if the orientation is not right. You got to learn to unroll it so that it's not scrolled. You have to be able to confirm the orientation either with the S stamp or with the flashlight. Then you have to unfold it, get any of the peripheral folds out, and you have to center it. Now, most people you talk to center the graft before they unroll it, but I'm going to show you why that's not as a good technique. To center it first and then unroll it requires that you're able to manipulate the anterior chamber and flatten it, but you can't do that in every eye. And you're going to get some eyes where you can't unfold the graft because you can't flatten the AC. So with my technique, you can do this in any type eye. And so I say my technique, it's not really my technique. This is something that was first done by Frank Price, 10 years ago. All right, let's show that again. All right, so that's flipping it, okay? So again, you see the orientation here. Maybe it's not in the correct orientation. The folds are upside down. So you inject fluid underneath the graft, and it comes around the AC, flipping this thing over, just like that, okay? So now to unroll it, this is where you tap the cornea. We're trying to get it to unroll. You can either tap the cornea, and then you see the rolls expanding there. Or the other thing you can do is you can tap a paracentesis or the main wound, causing fluid to come out of the eye, and that will unroll it slightly, okay? So here's an example of that. So I'm filling the AC, and then here I'm tapping my incision, and you saw how it opened a little bit. Even more so. You see where I let fluid out of the eye there? It unrolled. Now we're getting it into the orientation that we like. I call this the Tricorn hat, and this is my goal when I'm unrolling it, is to get it in this configuration. To me, it doesn't matter if it's in the center of the cornea or it's a little bit in the periphery. As long as you have this orientation, you can be successful with the surgery. All right, so again, this Tricorn hat. Now, this hat can be upside down or right side up. That's what you have to figure out, okay? And the way you do that without an S stamp is you use a flashlight and you shine it. And you can see there's 2 separate shadows here, 2 separate white bands that are separated, 2 white bands. That tells you that it's in the correct tricorn orientation. There's 2 separate bands. If you just see one distinct long band, it means it's upside down, okay? And so I'll show you here. 2 distinct bands like this, it's in the correct orientation, okay? Ignore this cannula. It was just the best picture I found. If you see one long band like this, it's in the wrong orientation. It's upside down. So we'll show you again here. When you see two separate bands of light, you know you're in the correct orientation. Okay. So once it's in the correct orientation, this has been confirmed, then I use a 30 gauge needle and 0.5 cc's of air, and I go in and inject an air bubble under it. And I call that the small air, okay? And what that does is that's gonna help you to unfold that graft. So I use the different verb here, unfold, as opposed to unroll. To me, unrolling is when you're getting it in that tricorn hat configuration, and then you confirm orientation, and now you have to unfold it. Because there's two kinds of folds, okay? And we'll get into that. But here again is where I'll go underneath the graft and put that air bubble. Again, slowly. Now look at this big pupil here. This is as small as it's getting. What if you had to collapse the AC and smush the graft on top of that IOL? That's not going to be good for the graft. And that's why this bubble technique is better than flattening the AC to unroll that graft. Okay, now, so let's just talk a little bit about what we did here. So we unrolled the graft already, then we confirmed its orientation, and now I put the small air in so that I can unfold it. So that's a fold right there, okay? That's a fold. And so there's two types of folds. There's one that's it's called a rolled fold like this. It's just a straight fold like this. And then there's one called the point lock fold, where it folds in the shape of a triangle, and there's a little point of the fold there. So once you have an air bubble like this in the eye, if you push here, that will get that to unfold. But the rolled fold like this, you have to be able to push in between the fold and the bubble so that the bubble comes up into this fold and opens it. So we're going to show you some energy. Again, the point lock fold, easy. You just tap right here on the point lock. The rolled fold, you have to use a traction suture to rotate the globe so that the bubble is coming up the hill, and then you tap the space in between the bubble and the fold using the bubble's kinetic energy to unfold the graft. Okay. So here's a rolled fold. You can see that straight fold like I'm talking about right there. So I just deepen the chamber a little bit, and now I'm going to use that traction suture. I'm going to rotate the eye this way, and then I use that space between the bubble and the fold, and that was an easy one to get out. Here's a little more difficult one because excuse me, let me go back here, because the fold is the fold is a little bit bigger. So there, I'm rotating the eye, and then I'm using the cannula, I push down, and then I release quickly and use that graft to come up and kind of release that fold. And now the graft has been decentered, and so I'm going to have to recenter it, so I'll show you that. All right, so getting a point lock fold is even easier. You can rotate the eye, and then you just tap on that fold, and it opens like that. Then, once you've had it unfolded, then you want to center the graft. And you want to rotate the globe so that it goes down the hill. You want to use smooth, broad strokes, and the eye can't be too firm. So here's a video of centering it. Getting rid of that last fold. And then I rotate the eye so that it's going this way. And you can see, just with some gentle strokes here, I get it centered in the area that I wanted, inside my blue marks. And once it's centered in my marks, then I'm good. Then I know that graft is going to be okay. So that's nice and centered. Now, if you center the graft first before you unroll it and unfold it, you have a little less control over this aspect. And then the last step that you do is you fill the AC with air. So I go back in a paracentesis. I gently go back to where my other bubble was, and I enlarge it. And that gets us a full fill. Now, if the eye doesn't have to be firm, it just has to be moderately firm. This may not yet be moderately firm, and I have to go back and give a little more air, but it doesn't have to be a rock hard eye. So here's just a little video of all the moves. So again, we're trying to unroll it first. So here are the tricks of flipping it and the tricks of getting it to unroll. So I'm trying to unroll, to flip it there. Now I have a good orientation, but I want to confirm if it's the right orientation. So I use the light, and this may be hard to see in this video, but I think I have it the wrong, oh no, I had it the right way. So now I go under the air bubble, being careful not to damage the pupil, and I put that little air bubble underneath it. All right, that's the little air. But now I got the folds, so now I got to unfold it. First, I deepen the chamber a little bit because it's is too flat. All right. And now these are point lock folds. So I rotate the eye so the bubble's coming uphill, and I tap on the point lock fold there. And there you go. Voila. And then kind of same thing on this side. But I got to rotate the eye now because I need the bubble to help. So point lock fold, rotate the eye, touch the tip of the point right there, and there it's unfolded. Now some golf swings to get it centered, and I like that. And then I'm going to augment my original bubble. That's 2 bubbles. That's not quite as pretty, but we got it. And there we are. So those are all the steps. All right, so I'm going to fast forward. We already saw the steps. And then the patient lies flat in the post-op area for 45 minutes, and I bring him back to the operating room, and you can see in this video down here, I use a 3C syringe filled with BSS, and I go in, and then I aspirate some, put a few BSS in there to try to get fill the AC a little bit, get a meniscus on the bubble, and then I suck out some of the bubble, just enough to clear the same size as the graft. And the eye doesn't have to be firm at this point. And then we do patch and shield, and we see the patient the next morning. In terms of post-op care, you see him the next day. It's helpful to use the OCT to confirm the graft position. And then I see him again 3 to 5 days later, because if there's a detachment, it's generally detached at that time. So when to rebubble, this looks like a less than 30% detachment. So it's a shallow peripheral detachment. What I would do is I would not rebubble somebody like this. I would just have them maybe position more. Maybe they weren't doing it in the correct orientation, but just get it where the bubble would be under this area. If they come back on day 3 and there's a bigger detachment and it's on both sides here, they would need a rebubble. So I would do that under topical anesthesia in the procedure room. And generally you can get them to stick. So you need to never give up on these. If your surgery was good and solid and you had that correct orientation, you can keep fighting to get that graft to stick. I think I've rebubbled 3 to 5 times in the past to get a graft to stick. And again, anterior chamber OCT helpful. In the clinic, I use a 30 gauge needle on a 3cc syringe, and I have them lay flat again and then remove the air just like I would on the initial surgery. Again, don't give up. Some other OCT findings that are maybe not as great. Here's one where it's scrolled up on the iris. That would be a bad scenario. This is my OCT, by the way. So on this patient, you just have to redo the surgery. And I would use new tissue. In terms of long-term post-op care, I get the patient down to prednisolone acetate 1% Monday, Wednesday, Friday for life. And these eyes heal faster than DSEK. They're seeing good. They're seeing well, like in 2 to 3 weeks. So we normally do the other eye about a month or so after the first one. I'm going to skip through the complex cases because I think we only have about 10 minutes. And then we'll go through our ending questions again, and then we'll take any questions from the audience. So which of the following would be a contraindication to DMEK? Ahmed tube, aphakia, poor view, iris defect, and PAS. So remember, PAS is not always, if there's 360, yeah, you're right. You pretty much can't do any kind of endothelial keratoplasty, but iris defects can be problematic. Poor views can, but there's only one on there that's a true contraindication. We'll see the results of the poll here. Okay, so I think that aphakia would be the winner in my opinion. We had this one right already, so I'm going to skip that one. And then in DMEK phaco, what should be the refractive target for a plano result? There's a range, of course, and there's no absolutes. But more or less, we got to get the gist that we're going to aim on what side of plano. So see the result here. Yeah, so everybody got that one right. That's good. And I want to thank you for your attention, and I'm happy to take any questions that you guys have. Okay, so I'll go to the questions. Okay, so anonymous attendee, what is the meaning of DSEK and DMEK? Okay, so DSEK stands for Decimates stripping and endothelial keratoplasty. So that's the version we showed you, the original version. DMEK would be Decimates membrane endothelial keratoplasty. Basically, DMEK is just replacing Decimates membrane and the endothelium, and DSEK is replacing those two plus some posterior stroma. That was also prepared by a microkeratome or manually. And then can we do, Dr. Pandya says, can we do DMEK and ICE syndrome? Any special precautions we have to take for it or not? Yes, you can. But that doesn't mean they're not going to have problems still with the glaucoma aspect. But yes, I have not done a DMEK and an ICE syndrome, but it can be done. I also would kind of take into account the iris issues, like keeping the bubble happy and everything like that. DMEK and ICE kind of depends on the severity of the case. So kind of in summary, yes, it can be done, but it depends on the case. If there's very little iris and they have bad glaucoma, I would fix the glaucoma first. I would do the cataract surgery part first, and then possibly come in with a DSEK if the view's bad. It all depends on those complex anterior chamber questions that I raised. So, okay, the next question is by 1+6. Donor preparation by different technique can affect outcome. Yes, obviously you got to be gentle. The donor preparation is as difficult as the surgery, but it's something that you can practice in a wet lab and get very efficient at. I think putting an S stamp on it does damage, obviously, where you're putting the S stamp, but they're still can have success with that. So it's just like anything. Once you develop your technique and you become efficient at it, you're going to have good results. The tissue I get from the eye bank is all good. I haven't had a primary graft failure from in the last 2 years or so, but often you can see if the preparation was traumatic with the stain. If you put stain on that and you see the dropout of endothelial cells, you know that it was a rough preparation. So you'll learn that as you play with it in the wet lab. Dr. Singh asks, when the graft is introduced, is the scroll with endothelium on the concave or the convex side? So the graft is always on the outside. It always scrolls out, okay? So depending on the configuration when it comes into the eye, you got to remember it's scrolled like this all the time. So it's the endothelium is on the outside, okay? That's the difficulty in the surgery. So that's what you have to fix by using bursts of BSS to get it in the correct orientation. Now, a lot of doctors really fixate on how it's going to be introduced into the eye and try to get it in a double scroll configuration, but it's difficult and it can make the surgery shorter, but you still have to be able to manipulate the graft because it doesn't always end up that way. All right, and then Dr. Manda asks, would you just explain again why aphakia is a contraindication? Well, you can't get you can't get that graft in safely in DMEK. A DSEK you can put a safety suture through and bring it in the eye under a sheets glide or something, and then use an air bubble to stick it. But you can't really suture a DMEK. So if you put a DMEK in an aphakic eye, I mean, where's it going to go? It's going to fall back onto the retina. So that's, in my opinion, why it's contraindicated. Now, if you put an IOL in or you have some sort of scaffolding, that would be a possibility. But for me, I think DSEK's a safer surgery to do in aphakia than DMEK. Also, aphakic eyes, generally speaking, if they have no iris, they got some problem with them that is going to decrease their best corrected acuity, and you may not get the benefit of better vision after DMEK. So next question, how much is the best corrected acuity we can achieve after DSEK and DMEK? DMEK's 2020, DSEK probably 2025, 2030. It's also the speed in which they get it. So DMEKs see well real fast, DSEKs take a while. In a patient with 2 tubes of glaucoma, this is Dr. Idris. In a patient with 2 glaucoma tubes, already had a DMEK, what do you prefer, re-DMEK or taking out the glaucoma drainage tubes? So those tubes have to be trimmed. If they're sticking into the anterior chamber and they're anywhere near the graft, they're going to cause the graft to fail. That's why DSEK is sometimes harder in these cases because you can get retrocorneal membrane and stuff from the graft hitting like if the tube is on the angle and then hitting the graft. But I mean, the tubes may not have to be removed, but they would have to be trimmed. If there's 2 tubes, do you know which one's working, which one's not working? You can remove the one that's not working and trim the one that's working. That's what I would recommend. Okay, and then Dr. Panja asks again, if a graft got flipped unknowingly, can we change it after the first post-op day or immediately? If the graft is flipped, you're killing it. Like, it's done. Like, if you put that air bubble under it and stick it with the endothelium side onto the posterior stroma, the patient's going to have severe edema on post-op day 1, and the graft's going to be dead. So flipping it in the clinic the next day is not going to do anything for fixing that problem. The surgery has to be it has to be repeated with new tissue. And then last question I have here is, when operating on a PBK, do you strip off the endothelium? Absolutely, yeah, I think you do. You'll find that endothelium is bad. It's opacified, and in this case, you can stain it with vision blue. Vision blue won't stain endothelium normally, right? But it will if it's all damaged, like it is with PBK. So in these cases, it's very helpful to stain the endothelium with vision blue or trypan blue prior to removing it. Also, you'll find that there's a retrocorneal membrane sometimes. You'll find that there's adhesions to the angle. So in PBK, especially if the eye is real bad, that you definitely want to remove the endothelium. All right, looks like we got them all answered. So I appreciate your time. It looks like we have to be finishing now. So thank you for your time. And if any of you have any questions, you can always contact me by email. That was the last shot there, but it's Lehmann, Lehmann @focalpointvision.com. I'm happy to answer any questions, and I'm happy to talk with you guys independently. So thanks again for your attention.